the 45 minutes that I may be given is I want you to understand a little bit of the difficulty that we have actually defining ALS. What is ALS? So that you can't really treat it unless you can define it. And that's part of the problem that we have. We can't treat it very well because, as you'll see, some of the definition is a little difficult. What causes ALS? And how important is it in terms of incidence and prevalence and perhaps impact? What are the treatment options that we have, and what's coming down the pike? And this may or may not be of interest to each and every one of you, but certainly your patients, I think, may be interested in understanding what's coming on. So I just wanted to touch on that. So what is ALS? Well, this gets a little arcane at this point, but we're going to have to discuss a little bit how we define a disease. And there's sort of hierarchies of disease classification, and the simplest one, as you can all understand, is just what are the signs and symptoms of the disease, like migraine headache, for example. That's how we define migraine in terms of just what symptoms people have. A more refined system is to say, well, can we use the sort of histopathology under a microscope to help us with the diagnosis? And that's what we do, for example, with lung cancer. An etiological cause is perhaps a little more sophisticated again. This is saying this is what causes the disease. So we're now going to define a group of patients in terms of a causal agent. And most infectious diseases are started that way, and sometimes you even go to what diseases respond to a particular treatment. And usually there's a progression as we become more sophisticated in our understanding. For example, ulcer disease started off as simply a syndromic classification, but then as time's gone by, we've recognized that there's an infectious agent, and we define it in terms of its infectious etiology, the H. pylori. And we formalized this with a presentation in El Escorial in Spain, where people got together and said that for a diagnosis of ALS, we need the presence of a lower motor neuron degeneration, either by clinical features or EMG or neuropathology, an upper motor neuron by clinical exam, and it has to be a progressive spread. So we like to see a progression of the illness. You have to see a progression of the illness. A static illness cannot be defined as ALS. Okay? And then you like to say, because we really don't know the cause, we're saying this is what we're going to include, and then let's exclude all the other things so that if someone's got really bad neck disease, it's going to be difficult for us to make a diagnosis of ALS, because that could be an alternative explanation for the lower motor neuron findings, or even the upper motor neuron findings in the legs. Try and make this a little firmer. We've broken up the body into parts in sort of the brain stem, the cervical region, thoracic region, and the lumbosacral region. And here for the lower motor neuron, you see atrophy and fasciculations. And upper motor neuron, I've just put the signs there. And what we've tried to do by this is to say that if people have more of these, then we're more likely to be comfortable in our diagnosis. Now, you will hear, and perhaps some of your patients have, or you will hear, about progressive muscular atrophy and a primary lateral sclerosis, which are two other closely allied motor neuron diseases. And I just want to go through the differentiation of them and how this is becoming more and more difficult. So again, to go back, the first description of a predominantly lower motor neuron involvement without the upper motor neuron that Charcot described as well was by Cuvier, and he described this as a primary muscle atrophy. And the primary lateral sclerosis by the father of German neurology, a guy called Wilhelm Herb, and he described an upper motor neuron muscle disease without the lower motor neuron features. So at the turn of the 20th century, now a little more than 100 years ago, this is how we sort of conceptualized this group of motor neuron diseases, one with a predominantly lower motor neuron presentation, one with an upper motor neuron presentation, and then ALS, which was in the middle and had both. So what causes ALS? Well, most cases, as you know, we have no idea what causes ALS. But we do know that some disease is familial. And about 5 to 10% of ALS is familial, inherited, usually as an autosomal dominant. And the familial ALS and the sporadic ALS look identical. So if you're not allowed to ask about the family history, you can't tell them apart. And the neuropathology is identical, and the progression can be identical. And as a result of that, we've always had this great optimism that if we could only understand familial ALS, then we would understand all ALS. And it's forced us to reconsider how we classify this group of diseases. And it's also forced us to consider, well, maybe all ALS isn't quite as malignant as we've always thought. Maybe there's some milder cases of ALS, and maybe even, who knows, asymptomatic cases of ALS. A little bit like people with asymptomatic multiple sclerosis, where you see it on an MRI scan, but you don't have any features. If you look at the different sort of mutations, and I've told you already about, most of them are autosomal dominant. Most of them have an onset in their sort of 30s to 40s to 50s to maybe 60, okay? Which means that those people are asymptomatic for 50 years of their life. And then they get disease. Their survival can be very truncated, as you can see. However, some of the people that inherit the gene don't get sick. And it's not just they don't get sick because they're run over by a bus when they're 25. Some of these people live into their 80s or 90s and they don't get sick. So we don't understand that either. That's one of the clues to ALS. How is it that people that inherit a mutant gene don't get sick?